I'll turn on the recorder and we'll go ahead and get started. This is, gosh, our first interview of an industry expert. Um, the topic today is on medical device data security, and the industry expert that we have is Caston Thomas. Caston is known unofficially as the Chuck Norris of data security.
Oh, it's official
And,
now.
oh, okay. So he has been developing enterprise network strategies since the late 80s. And he must almost be as old as I am.
Almost.
And deploying data security technologies in large organizations since the late 90s. So he has over 30 years of corporate IT experience, a lot of it focused on healthcare. And in his most recent efforts have been focused on data security. So um, that is our guest. Um, Caston, let's start with the first question, and that is, what are the real risks of malicious software regarding medical devices?
Oh boy, what a wide open question. Um, I I think that what we should talk about first is the source of the attacks or the scenarios, and kind of rank those to set the stage for what we'll talk about. Um, as I would rank them from the least likely to most likely, we we suffer potential hacks, potential penetrations. First off, from nation states laying in wait. We don't expect that anyone's going to be hacking hospitals because there are so many other for human damage, if you will, but really for the the effect of cyber war. So hospitals and uh, other organizations aren't as likely victims of nation state hacking. Number two would be for profit or terrorist or I would say psychotic lone wolf attacks. That becomes a bit more common, but again, the fallout and meeting the objectives of people in that regard, it's just not likely. Where we really start to get into the real world kind of threats are from disgruntled patients, family members, or employees. But really, the most likely are those hacks that are those of unintended consequences. And the unintended consequences really are along the lines of ransomware, DDoS, um, uh, IoT attacks like happened last year, and so on. So it's those vulnerabilities that we have that really come from the more recent attacks, perhaps a high powered, high processing capability using idle compute cycles for Bitcoin mining. That's certainly not out of the realm. So it's those unintended consequences that someone might hack a device not knowing that it has a severe impact on human life, but can really impact that device from a performance standpoint. What I think we have to worry about with hackers is understanding how they operate. Typically, the large penetrations like ransomware or other hacks are well known. And that's because the hackers will tend to collaborate and build toolkits that other hackers then monetize or use to a great degree. So uh, the question is, as medical devices become more of a target and it becomes more pronounced what the advantages of hacking these devices will be, is it's going to be a flood of penetration. And the question that I often ask is, do you really want to wait? And the other thing is that if we're patching these devices and making them more impervious to attacks, there's also a side benefit that we gain greater resiliency of those devices. The patch management gives us a better level of quality. And that also helps us as business people going to the executives to be more persuasive to get the executive buy in that we need a way of managing, updating, and securing these devices as the overall quality management practice of managing those devices. Does that make sense?
Yes. Can you give us a couple of examples of some recent exploits that have been
Oh,
successful in the wild?
sure. There's one of particular interest that happened last May during one of the massive ransomware attacks, and uh, it hasn't been publicly disclosed who that is, but we do know enough information to know that it was probably an MRI device, and the way that it was affected is that it was delivering a contrast agent to the patient, and the delivery of that was affected in some way. Uh, the other statistic, there's a great organization that does fantastic research, and it's called the Ponemon Institute. And they did a survey middle of last year, and they found that 41% of hospitals are aware of an adverse event that affected a medical device due to a security issue. And then there's an organization, yeah, that number surprised me as well. Uh, there's an organization that meets annually called DEF CON, very popular black hat and white hat conference in Las Vegas every year. And if you go and search DEF CON and medical device hackings, you'll find some incredible videos out there on the potential. And the great thing about DEF CON is they're not giving enough authorization information to hack from, but they're really showing the potential and demonstrating ways that devices can be hacked without showing the operational effect of how that's done.
So, what are some of the root causes or main factors that make medical devices vulnerable?
Oh, uh, I would say really there's four. The first I would categorize as denial. Denial from the standpoint of the executive suite looks at this from the perspective of nothing bad's happened yet. And so it doesn't garner that attention that when something really bad with a sentinel event happens, uh, the media, legislation, entire attention will be turned on the executive suite, and we'll see that happen. We saw that happen as a result of Target. We saw it happen as a result of Equifax, where heads are rolling and there's just a whole social upheaval that arises around the problem that's occurring. So that's one. We need to do a better job as information security and clinical engineering security people to communicate the real threats without yelling fire in a crowded theater, if you will. We really need to communicate the impact, the risk, and that's what I'm hoping that we can really tune into in the webinar here. So one, I would categorize as denial. Number two, complexity. Anyone who comes into medical device security or information security as well is overwhelmed by the complexity, not just of the threat surface or the attacks, but all of the steps that need to be done. And we'll touch on that as we go through it. Another issue, number three, for root causes of the risk that we face, I would say are silos. The silos in that the way that clinical engineering, information security, the networking team, the compliance team view the world has been really constructed in almost a conflictual way, because improving security affects user experience and affects the amount of time that the network team can utilize their time in improving the quality of the network, and then their attention is turned to security or having to deal with those darn medical devices that come onto the network in an entirely different way or create traffic patterns that mess with their processes. If we can move away from the silo approach that we use to medical devices and become more collaborative in dealing with those silos, we're going to be terrific, aligning everything. Number four, and this is more of an industrial side of things, is that uh, the question of who's responsible. The responsibility from the standpoint of medical providers is that it's the device manufacturer's problem. The medical device manufacturers think that it's the end user's problem. So there hasn't been a total agreement and assuming the responsibility of protecting the devices and making sure that, again, taking a collaborative approach as an industry is something that we really need to push for.
Well, for years, manufacturers have told customers that, well, we can't patch that latest, security patch for Microsoft because the FDA won't allow us,
Right.
which is not factually correct. It's a nice way to put that. So, when all's said and done, what percentage of devices out there in the real world do you really think are vulnerable?
Anything attached to the network is vulnerable. I
So,
think that what we have,
all of them.
yeah, everything's vulnerable. The issue is how many are largely vulnerable. And if we come back to that issue of 41% of hospitals have seen an adverse event on a medical device, I think it really points to the preponderance of that. The issue is, what steps do we need to take to reduce that vulnerability uh, to a reasonable manner? And now we move away from the complexity and we talk about what are the steps that we can do to get the most bang for their buck and the most bang for the time that we spend in doing those activities that are really going to lock down the devices and get them to the level that they aren't, quote, easily vulnerable.
Well, Christoph asked an interesting question about the FDA's role in all of this. And really, the FDA cannot pierce the veil of commerce. So they're only legally allowed to regulate manufacturers.
Right.
And they have, through their guidance documents, um, uh, created a framework or a threshold. This, if you need to be able to do at least this much, demonstrate you have valid security controls in your quality system for the design and manufacture of your product to get clearance. And in fact, I had a client um, uh, about a year ago that had a 510K submitted and the FDA kicked it back because they didn't have sufficient data security controls in their quality system that were reflected in their FDA submission. And so we worked with them to implement all of those controls, document them, and then include that in a revised FDA or 510K submission that was made. So the FDA is doing their part for newly designed products, but with medical devices that have a life cycle measured in 7 to 10 or even longer years, the percentage of devices that have good security controls built into them is vanishingly small, and the FDA is not in a position to really cause providers to do anything. They just don't have the legal mandate.
Right.
Um,
Yeah, I'm of the opinion that it would be very difficult to uh, to regulate or make specifications for the FDA on the medical provider side. So the concentration on securing the medical devices to the maximal effect is very, very important. But the FDA, I believe, has done an excellent job in providing guidance and the tools and resources that we can begin to build a great framework, a great architecture for how to leverage the existing things, the existing networks and the existing devices and the existing procedures within the hospitals or the medical facilities. That guidance is very, very strong and very, very well thought out.
I guess it's time for another question, isn't it?
Yeah.
So what are the most common mistakes or omissions you find among providers' approach to data security?
Oh, going back to that,
Medical device data security.
going back to that Ponyman study from last year, and it is publicly available, and happy to share that with anybody who's interested. Um, they said that 17, and this was a self-reporting study of manufacturers and primarily hospitals, a few other medical providers. 17% of the medical device manufacturers and 15% of the hospitals who responded had self-reported that they had taken significant steps to secure their devices. What was frankly shocking to me was that 45% of those self-responding hospitals said that they had taken, quote, no steps to secure their devices. And quite frankly, that scares me. And so that's just a statistic of where the problem is. And as I think about this and the people who are attending, I'm going to assume that everyone in attendance has at least taken a few steps, but we'll also speak to those people who are really launching their medical device security program. One of the things that we touched on, but I believe a root cause of the problem, the mistake is people view it as too complex. If we take simple steps and eat the elephant one bite at a time, we're going to be very effective because there's a lot of people in the industry who've done really, really good work. There are hospitals that we follow and that we've worked with who've just done some incredible work in building an architecture, building a framework. And so we know the steps for being able to uh, build a compliance program and build a security program that one checks all the boxes and yet at the same time is also very, very effective. Another mistake that people make is they haven't well defined the roles and responsibilities, both in the leadership position and getting buy in from the leadership so that we make this a priority. It's something we all know that we need to do, but in the execution, it's those day to day problems that occupy our attention. And we need to carve out some of that time to do more of the strategic activity of aligning the organization. Because what we do know is that if you set the roles and responsibilities well across those departments, align them and start to look at this in a collaborative approach rather than a silo approach, things really start happening. I wouldn't say automatically, but as you chunk off the steps and prioritize and build against the controls that you need to secure the devices, the network, and the perimeter, things happen uh, not automatically, but with a great deal of efficiency. And
Well,
go ahead.
sorry. Well, this gets us to the whole issue of governance. What do you think are the key elements of good governance for this topic?
Number one, have a well documented plan. And there's really a, a great diagram that I've seen Gartner put out one, and I've seen a number of organizations put them out. It's a pyramid. And at the top of the pyramid, you start and you work down that eye in the pyramid that you see on the back of the dollar bill is vision. Create a vision for what you want your governance, your security, and your compliance programs to look like. From there, you can, out of that vision, emerges goals and principles that you want to adhere to. Out of that, now you have the basics to go and get the stakeholder buy in across the organization. Now it's starting to get the visibility, and you're setting in place processes that are going to make this work very, very well. From that, you can build your framework and the work that the FDA has done, along with NIST and with SANS and other security architecture organizations have put in place for information security models that we can use that are well tested, well proven, and apply that to the medical device sub community that happens in the overall cybersecurity in the organization. What falls out of that framework are the technologies and the execution model the policies and procedures, and the roles and responsibility. And that really becomes the foundation of that pyramid, because now that all those things are in place, you can do the audits, you can do the checklist, and make sure that you're actually performing against the goals and principles that you established up higher. And again, from my standpoint, the good news is that this is easily replicated. There are a lot of organizations who've done it. Hopefully your hospital, the CISO, and the information security architects have put all this in place so that they can make the same kind of guidance and process development to steer you through some of those potholes and give you the roadmap for doing that.
The FDA guidance on medical device data security calls out the NIST framework.
Mm-hmm.
And most of the medical device manufacturers that I work with are following that framework.
Yeah, and
I don't know.
it gives us a common languaging that we can begin from,
Mhm.
because most security certified people are very familiar with the NIST model. And so when we get in that room to hash out who's doing what, and the roles and responsibilities and policies and the controls that we put in place, uh, it just lets us communicate better from a basic understanding of what the terms and terminology means.
Well, how widely adopted are these best practices among hospitals, ambulatory clinics, and physician groups?
Oh, um, for hospitals, um, and the Ponemon Institute statistics bear this out. Somewhere between 10 and 20% are down the road of implementing best practices. I would venture to say that other health practices that don't enjoy the economies of scale of a hospital or a hospital system, I would put that number much lower than the 10%. So, but the good news for the rest of us is that the work that 10 to 20% has done is well documented. A lot of it is published, and it's already been developed, and it's really amazingly great work. Um, you know, I always believe in using other people's scar tissue.
Mhm.
uh,
Yes.
and there's just been tremendous work done. And I won't name names, but you know, uh, Minnesota, Arizona, California, Texas, Tennessee. Uh, there's there's been some good conferences, good sponsors, both on the academic side and on the practitioner side. So, and my company Interworks has built some of the boilerplates, and we've gone out there and scoured some of the best and the brightest for that information, to build some of the processes, templates, and boilerplates that we use to help our customers.
What kind of barriers do you see then for adopting this kind of governance in provider organizations?
I'm starting to sound like a broken record. Number one, there's no clear mandate for who's responsible. There's a lot of assumptions and interplay, but uh, as we go through that uh, pyramid, I constantly focus on getting the buy in, getting the leadership, and well defined roles and responsibilities. And I guess that's number two, too. Number one would be that well defined mandate. Number two would be go back, get the executive buy in, set the priorities and the timing and the goals.
Let's sort of transition to more of the technology side. How do we categorize the different types of medical device security?
Ooh, um, I would categorize it from a high level approach to what the controls are. You know, first, before you do any of this, you need to set the standards. We've defined kind of 20 solid controls. But as you break those out, I would say number one, the device. You know, you need to change the default passwords. You need to have an update and patch policy in place with the audit and uh, internal certifications that you're doing that on schedule, and then the testing to make sure that the patches were properly applied. You've got backup, you've got authentication. You know, one of the great tools out there is a tool that's publicly available free, and it kind of does what Google does for network devices, called Shodan. Log in, no charge. You can run it against your organization, and it will give you a view into what devices are out there, what's the version, what's the vulnerability, does it have the default admin password, things like that. Really scary what it is. It's a research project that's about 6 years old, but I'd highly encourage people, if nothing else, go out and run Shodan. If it doesn't scare you, then you've either done a really good job or you don't know what you're doing. So, you know, and you've got to have your asset management, asset tracking piece to that. So that's just at the device level. Other levels are the network controls, you know, segmentation, intrusion detection, log monitoring, vulnerability scanning, those kinds of things. The perimeter devices, the firewalls, are those properly set up to apply to the medical devices? And again, a lot of these things are the technologies that information security has already put in place. It's just a matter of ensuring that the configurations and the exposures, that threat surface, if you will, has been designed into the way those devices are set up for the network. Um, you've got testing, security and penetration testing. You've got your incident response and making sure that uh, how you respond to an incident has policies and escalations and the procedures that are necessary so that you can do it by the book. Doing tabletop exercises. We can't forget user training and staff training so that they know what's going on. And then the whole audit and evaluation stage, making sure that the controls and the processes that we have put into effect are actually being accomplished successfully.
Now, there's been a lot of medical device data security vendors that have started up in the last few years.
Yeah, I think
And
there's about 6,000 of them that actually have.
it seems that way. Um, do medical devices require their own specialized data security solutions? And if so, why?
No, um, I would say yes, but I'd also say no. The reason I'd say no is that for most organizations today, that 90% who hasn't fully implemented best practices and are far down the road, uh, just doing uh, the basics and building the program and using the existing technologies and processes for the medical devices is really where we're going to get, quote, the most bang for the buck. You know, it's a matter of let's focus on those things initially that don't cost us money and mean that we don't have to go to the executives with a big price tag, because ultimately, to be successful in building a program, you have to have executive sponsorship, which means they're opening their wallets. And until we have that massive, high visibility, wake them up, I call it a target moment, where something really bad has happened, getting the full attention endorsement of the executive suite is an uphill battle. It's just the reality. Because again, they come at it from the perspective of, well, nothing bad's happened yet. So as as we move forward, if we can do those things that don't cost a lot of money and are leveraging those other security parameters that we've deployed in the hospital, it's going to be much, much more effective. Because now that we've done that, we're going to understand those medical device mechanisms to tie down that last 20% of the security vulnerabilities that are out there. But there's some really great technologies that have come out that the IT security people may not be aware of that can help both IT security and medical device security with the same kind of infrastructure. Because if clinical engineering and the network team and the disaster recovery team and the compliance team can go with a unified view to get budget approval and buy-in from the executives, that business case again leverages the economies of scale. Um, there's one great technology when it comes to network segmentation. I know hospitals that have had the information security team and the network team have had network access control, or NAC as it's called, on budget for maybe as long as 10 years, but it always gets cut before it gets to the implementation stage. That's because it's a massive undertaking that requires a lot of resources. And quite frankly, the success record of implementing NAC in hospitals has not been tremendous. They tend to run over budget and take 2 to 3 times as much time to get implemented and resource drain as possible. Uh, the new term in that is called the software defined perimeter. And there's one particular technology. I'm not going to talk a lot of technology, but we're excited about this because the leadership of the organization is tremendous. It doesn't require any changes to the core network and can essentially cloak the medical devices from the rest of the network. And this is the same technology that's already being deployed to secure airliners as they come into an airport to do their data dumps and uploads inside the airport. It's being used to secure electric smart meters and the electric grid. So it's a well-proven technology that I believe is ready for prime time for a hospital market. The vendor happens to be Tempered Networks, and we're finding that their cloaking mechanism and what they're doing in these other industries is going to be very, very applicable to what we're trying to do in hospitals. And I've been so bold to say that it's going to replace NAC because of the ease of implementation, the way that it works without restructuring the network, and quite frankly, the minimal amount of support that it takes to secure the devices on the network and make them unavailable to the outside world or to unintended people inside the network as well.
If we have some different data security solutions for medical devices with special capabilities, how does that get integrated with a broader IT data security framework?
Well, again, we go back to let's use the tools we have in place and make the most out of those. And then as we're looking at the specific tools to secure the medical devices that are different during the evaluation process, during the procurement phase, we really want to emphasize those vendors who integrate into the existing network, the existing help desk tools, and do that on the front end. Because if we purchase those tools without having light into how that it leverages what we already own and what we're already invested in, it's going to be an uphill battle to get that integrated, because now we've got competing technologies that we make a change over here and it has an unintended consequence downstream at some other point in the network, or in opening up unintended holes that again has that unintended consequences. I kind of liken it to my drill at home. You know, I've got my handheld drill and it's got the screwdriver attachments and the wrench attachments, even a buffing attachment. That's 95% of the time what I'm using to either break something or fix something, whether I'm drilling a hole or screwing a screw or a nut in, or bolting something in. It's indispensable. But there's that other 5% of the time where I need a handheld screwdriver, or I've got a tight situation. So I wouldn't say it's an 80-20 rule, but I would say that 95% of our security and medical devices where we are today can be done with the existing investments that we've either made or we intend to make on the network side, on the device side, and leverage the economies of scale.
Simon Crowley asked, what are some good sources for threat intelligence? And he said he's looked at the FDA, which not really a good source for that. The
I'm
ECRI
sorry,
Institute.
can you repeat the question? I got hooked on the Simon Crowley part.
I'm sorry. Do you have any tips or sources for threat intelligence for medical devices?
Oh, not off the top of my head that I can quote right now, but I'm happy to respond to everyone who attended and get an answer back to you on that.
I found the LinkedIn medical device group, the medical device security group, sorry, is pretty good. Obviously, it doesn't have the detailed reports and things, but they reference a lot of that in the updates that they provide. So
yeah, I took the question, Simon, to me more along a line of a more sustained stream of intelligence coming in, like what happens in the information security environment. So I'm thinking more along the line of the productized service types of threat feeds that come available. So
gotcha. So specifically, what kind of components are we looking at for medical device data security?
well, I think I really already touched on that, but
Okay.
just rehash it. You know,
Yeah.
go back to the architecture, go back to the FDA guidance and NIST, and we're kind of walking down that pyramid again. Start out by assessing the risk, and that needs to be an ongoing thing. I think that goes without saying. Build the alliance with the network team, the information security team, compliance and privacy, to leverage that. Those are all the internal collaboration pieces. But from the standpoint of the technical categories, we come back to 1, device security, 2, network security, 3, perimeter, testing, audits, incident response, and reporting and support issues that go around that. So that's kind of the high level. How do you categorize it? How I would categorize it. And each of those categories are going to have functions for things that you need to do, both on the defense side, but on the response side as well.
Given that we have a lot of things evolving and coming together, building in the security in the design controls for medical devices, really rapidly, hopefully rapidly maturing data security efforts in provider organizations, and along with that work, human powered work, the acquisition and deployment of medical device and data security tools and just IT data security tools. How do you see this all coming together in a timeline? I mean, is this going to be all taken care of in 3 years, or are we going to be doing an interview like this that will have very similar questions and answers 10 years from now?
Oh boy, that's a roll of the dice, and I tend to look at the world through a lens of process. There's never going to be a point where we say we're done. There's never a point where we say we've got to get started. For the majority of us, there's and I'm talking from the Pawnee man and observation. For the bulk of us, it's getting beyond that complexity, eating the elephant one bite at a time. You know, putting the pieces in place organizationally, getting organizational buy-in, getting organizational priorities and goals, and then setting out from there. Uh, most organizations have not done a complete job of doing that. And I think that even some of the organizations who say that they haven't taken any steps to secure medical devices, if we came in, we'd find that there were some things that are done, maybe not even knowingly, but just because their service providers or manufacturers put those things in places, they've done more than even they think, just because uh, the integrators and the manufacturers don't want that liability. So um, uh, I just don't have a good answer about when or how. I think the more important thing is do as much as you can with what you've got and prioritize it in a way so that your time and your budget is actually optimized. And hopefully, and I can be more clear about this, um, using those things that are already in place. That's a great strategy because the leadership and the budget resistance to getting those things done is going to be much less. It just requires that discipline of doing it. The nice thing is that with the boilerplates and templates and the guidance of somebody who's already done this, the steps are clear, they're concise, and they can be implemented through a process that can be very, very effective. One of the side benefits we find is that once you start going down this path and the awareness is raised within the organization, things tend to happen faster than the initial realistic timelines that we put in place, just because of the visibility that it has and some of the early successes that we gain in getting those early successes by using the things that the information security and compliance team have already put in place.
Okay, well, we've got our last question here. And uh, what, this is a question really for provider organizations. What should they be doing right now? You've talked a lot about sort of in general terms, and you've talked a lot about the the complete solution and the right way to do it, and define the elephant and then start eating the bites. But what specific things can they start doing right now?
Got it. I would say there are three clear things that we do. Uh, and let's start from the most basic level for the organizations that have perceived that they've done nothing or they haven't put that vision and goals and priorities in place. Number one, create an internal document. Okay, and the document, we've built one, we've built a template at Interworks that's 12 tactical actions that every clinical engineering organization should do ASAP. And again, that emphasizes, let's not break the bank. Let's get those activities that are going to give us the biggest impact with the smallest budget, get those in. So that stated, number one, sit down with the departmental owners of security for medical devices. That's compliance, and privacy in most organizations is kind of an extension of that compliance. It's information security, it's IT leadership, and it's the network operations and help desk and support teams, either individually or collaborative. And it's not just, hey, let's have a meeting. It's a matter of getting that collaborative approach to attacking this together and using the skill sets that each of those departments has to really come after this at a systematic manner. So one, sit down either one-on-one with those departmental leaders or in a group to start building out and communicating effectively the roles, responsibilities, the goals and perspectives, and from that building the vision. Number two, after doing that, and these things can all happen simultaneously, devices. Put together a patch management program. Uh, uh, go out and do your Shodan research, because that's going to show some exposures that hopefully it doesn't, but I suspect that most people running Shodan will find some things that either surprises them or shocks them if they haven't done it before. Um, Another one where it's so easy to do, but it's been overlooked: change the default logins and passwords of all the devices. In order to do that, you have to have your asset tracking in place, so that, and that needs to be in a systematic way of making sure that every device has been touched and it's been properly configured. Number three, and that's why I spent some time talking about the tempered networks and the software defined perimeter: network segmentation and isolation, not just internally within the network access control or these new SDP technologies that are rapidly evolving, but also at the perimeter. And again, that evolves out of having that collaborative approach. Make sure that the firewalls and those perimeter devices and those other tools that you have to detect security threats are in place and specifically configured to address the unique needs and requirements for the medical devices.
Very good. So that was our last question, and hopefully we've got some questions from our participants. Um, we've gotten some questions as we've gone, and we've answered some of them. Um, I did insert a link to the Ponemon Institute, so you can go look at their research. That they have some on hospitals and healthcare and medical devices, but also a lot of other research around data security. Um, do we have any other questions from the audience?
I see one from Josh about the technology replacing NAC.
Yes.
The popular term, if you're going to Google it, is the software defined perimeter. It's an outgrowth of Department of Defense research, and essentially it's a cloaking device that hides any device that's participating in that software defined perimeter to only be able to be known to the network by a device that has already authenticated and been given permission to know about it. Uh, uh, Google Research was very involved, and Google Research spun off a group called Beyond Corp, and they are heavily oriented around cloud services, and so we don't see that as being at least an immediate player in the software defined perimeter. The thing that I love about tempered networks, and there are some other great solutions. Uh, there's probably 10 people playing or 10 organizations that are providing products in this space that we think are reputable. But tempered actually has what they call a HIP device, and that's a physical device that either sits behind the wireless network or sits behind the switch network, the Ethernet ports, and provides that intermediary security piece so that it secures the devices. And they're based out of Seattle, and there are some hospitals in the upper Northwest that are actually collaborating to build tools specific to hospitals and the mobility of devices and the way they move around on carts and the way they plug into various rooms and so on. But that whole idea of being able to deploy an ultimately secure technology specific to medical devices to cloak them from the rest of the network without a lot of administration is just really, really fascinating. So do a little bit of learning, and I'm happy to talk to anybody about this offline or any of the things we've talked about. If we want to start a one-on-one dialogue, happy to do that. But learn about zero trust networks and software-defined perimeter. We believe that those two things are going to have a tremendous impact moving forward into how medical providers, and particularly hospitals, are able to secure their medical devices and create a sub-community of secure devices on the existing network without re-architecting any of the existing network.
I'm going to put your email address in the chat window for people who want to follow up with you afterwards. And Josh asked, is that a HIP device, or what's the name of that appliance?
Yeah, it's a HIP device. I think that
As in
HIP
cool?
stands for Host Identifier Protocol.
Oh, okay.
The great news is that the Host Identifier Protocol, there is a draft standard for that in the IEEE committee. So the same people who brought us the 802 committees and all the standards that we have in Wi-Fi and so on are working on this as the next way of securing the network.
All right. Any other questions from the chatters?
Oh, and Josh, you got HIP correct, HIP.
Well, it must be that good sound quality in your padded room.
Yeah, thanks. I think I needed the padded room for this. And again, I see that Simon, and there was some dialogue about ICS cert. That is a great feed. That's got a lot of feeds beyond medical devices. So I want to see if there's something more specific to the medical device trade. And if you're interested, you can connect to me on LinkedIn as well. Pretty easy to find.
Josh shared a little additional information that they're deploying a NAC strategy.
Okay.
And they're including appliances or embedded systems, building automation, and non-standard stuff in their NAC.
Awesome.
Very good. Well, I guess we'll wrap it up here unless somebody pops up with another question. Caston, I want to thank you for taking the time to join us today and share your expertise. And I'll be sending out later we recorded this, so I'll be sending out a link for people if they want to share this with other folks in their organizations. And thanks for participating.
Oh, my pleasure. Just always happy to talk security to me.
Right. All righty.
And really appreciate everyone joining us today. Certainly, I welcome a dialogue. It's great to learn, and we're doing good work. As an industry, we're doing good work. I think that we can just get a lot more organized within our individual organizations moving forward on this topic specifically.
All righty. Thanks again. Bye-bye, everyone.
Thanks, everyone.
Okay.